Thank you very much. So I am presenting on a topic using implementation research approach to design and implement strategies towards elimination of lymphatic filariasis in northern Ghana. You know, lymphatic filariasis is one of the 18 neglected tropical diseases, and the disease is transmitted by mosquito bite. So the mosquito bites someone that is having the filaria worm and pick the worms, and the worms go through developmental stages in the mosquito, and again bite a healthy person and transfer the disease to that person, and then the transmission cycle continues in a person. Now, the disease has a manifestation at the chronic stage that will have to be lymphedema, elephantiasis, or hydrocele in people that are affected. The strategy recommended for elimination of this disease is through mass drug administration that have been implemented in different parts of the world where the disease is endemic. Some countries, few countries have been able to interrupt transmission of the disease, hence eliminate the transmission of the disease. And in Ghana, the implementation of this evidence-based intervention started in the year 2001. 98 districts were endemic. After 18 years of implementing this evidence-based intervention, 76 districts were able to interrupt transmission of the disease through this strategy, and 22 districts are still transmitting the disease, which are known as hotspot districts. So now the question is, why is it that this evidence-based intervention that worked in other parts of the world and some other districts in Ghana is not working in some parts of other parts of Ghana? So this leads to the aim of this study to develop and test quality improvement strategies to effectively eliminate lymphatic filariasis as a public health problem in Ghana using implementation research approach. The study was in 3 phases. It's a cross-sectional study that is in 3 phases. We had the pre-intervention phase and then the second phase was the intervention phase, and the last phase was the post-intervention phase. Now, this is the framework that we use for the study. At the pre-intervention phase, we assess the barriers and facilitators to the implementation of the mass drug administration, and these barriers were assessed at the community level, the health system level, the the drug distributors level, and then the individual community level. And we use qualitative data collection approach, and again we use secondary data from the LF program. Based on the findings from the pre-intervention stage, we developed an intervention strategy that was implemented along the MDA that is ongoing, and after the implementation we evaluate the process and then the impact of this intervention, and we use a PDA cycle in designing and then evaluating the program that was we designed to implement. Now, after the first stage, the first phase of the study, these are the key barriers that we've identified, that the knowledge of the disease and then the MDA process itself is very poor among the drug distributors. They don't know much about the disease and why the drug is being given to the affected people. We also realized that social mobilization and then sensitization was not properly done. They only go to announce the people that tomorrow we are bringing you drugs. They don't educate the people about why they are bringing them the medication and what the medication is meant to be. And then the drug distribution process itself, they go and then distribute the drug, and people that were not present, temporarily absent at the time of the drug distribution, they don't go back and they go and follow up on those people to make sure that everybody is taking the drug. There were issues about the fear of drug reaction where people that had minor drug reactions were afraid to take part in the subsequent MDAs. And also, the drug supposed to be given to the people by DOT, directly observed treatment, but we realized that the drug distributors go to the communities, and people that were not present, they leave the drug for them to take at their convenience. And other people who don't want to take the drug, they leave it to them. So they give this drug to the people that don't take it in their presence, but they record it in their books that they've distributed the drug, and we don't know what happens to the drug after they've left, and it's a problem. We also realized that the community leaders and other key stakeholders were not involved in the drug distribution process. Now, after these findings, we had community engagement with the key stakeholders from the health system, from the local government, and also from chiefs and then opinion leaders, to be able to map up the intervention strategy that we'll be able to use to improve the drug distribution process, to make that the drug is getting to everybody and everybody is partaking. So these community people, they were involved in coming up with the appropriate strategy that they think will be able to use to be able to improve the distribution process of the drug. Now, after the brainstorming session, we came up with 4 key strategies that have to do with proper training of the drug distributors for them to have proper knowledge about the disease, and also the why they're giving the drug to the people, so that at the community level, they will be able to educate the people about why they need to take the drug. We also intensify social mobilization and sensitization so that everybody in the community will know why the drug is important for them to be able to interrupt the transmission of the disease. And the community leaders were engaged in this process, and other key stakeholders were engaged in this process in educating the community people for them to be able to partake in the drug distribution. And also, we improved the drug distribution process, that people that were temporarily absent at the time of the drug distribution, the drug distributors go back to those households to make sure that everybody is taking the drug. And this is being supervised by people from the health system to make sure that this is being done. And in this implementation package, these 4 strategies were defined or described under 7 domains. We identify who are going to be the actors, the actions that are going to be taken, and the targeted actions, the temporality, the dose, the implementation outcome that are expected, and of course they are justified from literature and other evidence. After implementing these strategies, we realized that there is 6.3 increase in the mass drug administration coverage, and also there is 0.11% reduction in reported adverse drug reaction, and there was an improvement in the knowledge about the lymphatic filariasis and then the mass drug administration process itself. There was improvement in social mobilization and sensitization in the communities, and also more people were willing to partake in the drug distribution. And also, we also noticed that the drug distributors were adhering to the DOT strategy. So we can conclude that it is visible to develop context-specific quality improvement strategy for an existing evidence-based intervention using implementation research approach, but mostly this knowledge that is needed to be able to improve this evidence-based intervention within the health system, it is not in the health system, because we need people with this background in implementation science to be able to identify these implementation gaps, to be able to improve on this evidence-based intervention that were recommended. This was part of a bigger PhD project that was supervised by the following 4 supervisors, and the program was hosted by University of Witwatersrand in Johannesburg, and then it's been funded by TDR. Thank you very much.
Ladies and gentlemen, I have the pleasure to introduce the second speaker, Andreas Felipe Rodriguez from Colombia. And this is a very clear show of multidisciplinary approach to implementation research. His background is in animal health. He's going to present his study for his master's project that describes the barriers that limit implementation of thermoflogging intervention in vector control for dengue in Medellin, Colombia. Thank you and welcome.
Thank you. Ladies and gentlemen, good morning. It's a pleasure to be here, and I am share with you my work that is about identify barriers that limit implementation thermal fogging intervention for vector control in Medellin, Colombia. This study was a collaboration of the University of Antioquia, Secretary of Health of Medellin, and Grupo de Entomología Médica of the University of Antioquia too. To start, it's necessary to say that thermal fogging intervention is a component of the integrated management strategy for dengue. Technically, thermal fogging intervention consists in a dispersion of a liquid insecticide into the air, and this is used to reduce densities of adult mosquitoes. This intervention is only effective while the droplets remain airborne. At the moment the droplets come down to the floor, doesn't work anymore. I mean, doesn't have residual effect. This intervention is recommended by Pan American Health Organization and World Health Organization, and is carried out in Medellin in places where it's not possible to access by a car, and another way to control mosquitoes like ultra-low volume is not possible. Medellin is the second largest city in Colombia, and Secretary of Health of Medellin implement thermal fogging intervention with 4 basic steps. The first one is a schedule that consists in identify areas where intervention is needed, and stakeholders identify these areas. The next is necessary to prepare intervention, prepare machines, prepare the insecticide, and prepare the papers. After that, officials of Secretary of Health go to the areas where intervention is needed, and they awareness to the residents. And the final of the awareness, official asks to residents if they accept the intervention. If the resident accept the intervention, they are registered and signing in a form. And this continues until all area is covered. And finally, when awareness is finished, start the intervention inside homes. So, despite Medellin implement thermal fogging interventions since 2007, expected control of dengue not achieved, and especially in some areas where previously were applied the intervention. Maybe some problems with implementation carry out. Problems like difficulty intervening when and where is needed, weak adherence to application guidelines, or low coverage because some residents reject fogging in their homes. For this, we propose a general objective that is identify barriers in a temporal and spatial opportunity of intervention, and identify barriers of the acceptability of the intervention by residents to propose solutions to improve effectivity of intervention. We carry out a cross-sectional observational study with a mixed method design and specifically explanatory sequential time. For this, we collect first quantitative data that was timeliness of treatment and rejection by residents. At the end, we try to explain this result with a qualitative approach. And we try to identify factors associated with rejection. This is a map of Medellin. Medellin is the second largest city, as I said before, and is the capital of department, the Antioquia's department. And Colombia is located in the northwest of the South America. In color green, you can see the neighborhood that we visited during the period study. And for data collection, we had 3 phases. To timeliness of intervention, we analyzing how quickly intervention occur post-notification and if it target of the location of infection. For this, we use public health surveillance system called CDGILA in Colombia. And we used to report of intervention areas by officials of Secretary of Health of Medellin. After that, we identify rejection bureau residents. For this, we went to official of the Secretary of Health to areas where intervention is applied, and we stay with the awareness. In the awareness, we identify acceptance and we reject in a format 1, register in a format 1. And we identify 2 rejection, and rejection was classified into 4. Active rejection was houses where residents listening the awareness but say no. And passive rejection consists in houses where it's not possible reach by intervention. At the end, by factors associated with rejection, we analyzing reasons residents reject intervention. For this, we use focus group discussion and looking for 3 means categories: experiences, meanings, and reasons related to the intervention, to rejection of intervention. Like result, we start to identify that days between notification of surveillance system and treatment had a median of 25 days. It's necessary to know that period stringent incubation period of the virus dengue mosquito in mosquito body is around 8 to 12 days. So go to 25 days is a little late. If intervention occurs in the location of infection, we identify that only about 22% was the correct location, because dengue cases of dengue stay at home the most time during the day. And all intervention was carried out in houses around of the houses of dengue cases. Respect, acceptance, and rejection of intervention, we identify that about 54% accept the intervention, but 46% reject the intervention. Now, this rejection was classified into 4, as I said before. Passive rejection was about 37%, and active rejection was about 10%. The main reason to passive rejection was closed house, and the main reasons to active rejection were about busy at the moment of the intervention, of thermal fogging intervention, or residents not interested about intervention. They say, no, we have own form to control mosquitoes. Additionally, we develop a questionnaire with some topics related to rejection to intervention. And we identify that rejection of intervention was associated with perception that fogging doesn't control pests other than mosquitoes. Don't see or don't feel mosquitoes inside home, perception that fogging affects people's health, and not previous intervention was associated with active rejection too. Like conclusion, we identified that high rejection rate was the main barrier to full coverage, and some attitudes and some belief can increase the rejection. The time between notification of dengue cases and intervention is longer than expected. Residents understand thermal fogging helps to reduce densities of mosquitoes. However, they also perceive it as a harmful to human health. And finally, we recommend 3 ways principally. First, to strengthen community education about thermal fogging intervention and about advantage of the thermal fogging intervention. 2, to carry out intervention on a schedule that will maximize access to houses, maybe on weekends or another schedule. And finally, to identify bottlenecks in the notification system to reduce time of the intervention. Thanks a lot for the Universidad de Antioquia. Thanks a lot for Secretary of Health of Medellin. Thanks a lot for my support for TDR, and strong hook to my 14 classmates in Latin American region. And thanks to you for listening to me.
Thank you. Thank you. So the third speaker is Atip Ahmad Parey. He's from northernmost part of India, the Valley of Kashmir. He pursued bachelor's in dental surgery at the University of Dhaka through a scholarship which was awarded by Ministry of Foreign Affairs, Government of Bangladesh, and he obtained a gold medal for his academic achievement in 2017. Atip received TDR scholarship for MPH in BRAC for 2018 and 19. He just got graduated in March this year. This opened opportunities for him, and as from an oral surgeon to a social researcher to a monitoring and evaluation personnel, his journey was shaped by the grants that he received from TDR. That's what he told us. Currently, he is a technical program officer at BRAC, and he's also a visiting research fellow at the Center of Excellence for Urban Equity and Health under the BRAC James P. Grant School of Public Health, BRAC University. So today, Atip is going to talk about hospital infection control in selected facilities managing drug-resistant TB in Bangladesh.
Thank you, Maz.
Thank you.
Good morning, everyone. It's an honor to be here. The profile seems long, but I'm a very small person. This study is based on my thesis, which I completed in James P. Grant School of Public Health last year, supported by TDR as a partial requirement of my MPH. So the presentation will shed some light on the drug-resistant tuberculosis, thus elucidating its threats and the need to study it from a holistic approach. However, I will also present how an explanatory mixed method design could be utilized to carry out a study answering both the qualitative and quantitative aspects of the questions involving infection control. At the end, we will also conclude with some recommendations for the drug-resistant tuberculosis facilities. The Global Tuberculosis Report of 2018 estimated around 500,000 people living with drug-resistant tuberculosis. However, only 1 in 5 received treatment and half of those got cured. This indicates that tuberculosis is a global pandemic and is at large as for what can be called as a return phenomenon in a rather more deadly and devastating form, having resistance to both of our first and second line drugs. The Global Tuberculosis Report of 2017 flagged Bangladesh among the countries with just a little less than 10,000 cases of drug-resistant tuberculosis. However, the annual report of National Tuberculosis Program of Bangladesh has estimated a total of 8,500 cases, out of which 944 are detected and only 922 are on treatment. This forecasts the huge gap we are at and also gives a picture of how much of this deadly disease is currently being spread in the community, thus corroborating the need to study infection control and strengthen it. However, tuberculosis infection control faces quite a number of challenges in terms of infection control, which requires laboratory armamentarium. And in the lower and middle income countries like Bangladesh, where patients exhibit diverse range of care-seeking behavior and the health system of the country is pluralistic. Moreover, it incurs an extra cost on the patient which pushes a family towards a probable catastrophe. At an average, a short regimen DRTB patient may have consumed a total of 16,000 pills by the end of the treatment, while the general TB patient may have consumed 750. This deadly infection also demands special infection control measures for prevention, which are elucidated in the WHO's tuberculosis infection control policy of 2009. This study was designed to capture a snapshot of the current status of infection control and the barriers preventing its practice in the facilities that manage drug-resistant tuberculosis patients in Bangladesh. The National Tuberculosis Program of Bangladesh is spread across a national super-specialized hospital supported by National TB Reference Laboratory and various chest disease hospitals for case detection and ambulatory care with support of regional TB reference laboratories. However, some non-governmental organization-owned facilities are managing what looks like the majority of drug-resistant tuberculosis cases in the facilities. And also, we pre-tested our tools in the National Institute of Diseases of the Chest and Hospital and conducted the data collection in 3 sites, that is Tangail, Mymensingh and Trachoma. So this study may not give a true picture but a snapshot of what's going on around drug-resistant tuberculosis. Since we intended to answer what and why of the infection control puzzle, we leveraged a sequential explanatory mixed method design to answer this question. The quantitative component preceded the qualitative component in all study sites. The qualitative guidelines were guided by the quantitative analysis of the data collected via 2 checklists employing non-participatory observation and document review. We observed the different areas of the study site and reviewed the hospital documents, followed by a quantitative data analysis and development of qualitative guidelines on basis of that analysis to understand the barriers accordingly. Frequency and proportion were used to analyze the key analytic outputs for the quantitative binomial data, while thematic analyses were accredited to explore the infection control standards if found any. The ethical approval was sought from the BRAC, James P. Grant School of Public Health, which is an independent ethical review board established in 2004. A total of 31 healthcare workers, including the managers, clinical staff, field staff, and support staff in the age range of 20 to 50 years were interviewed. Moreover, 12 patients from study sites maintaining the gender equity falling under the age range of 20-40 years were also interviewed. All the facilities were tertiary drug-resistant tuberculosis facilities, referral hospitals with the highest Upazila coverage being 35. Hospital 1 had the greatest number of patients. On the left-hand side, what we can see is an example of the physical layout of one of the facilities. Across the 3 study sites, none had separate budget component, especially for tuberculosis activities, which according to the End Tuberculosis Strategy is one of the most enabling standards for the infection control. Also, the time taken for one patient from screening to diagnosis, from the screening to the diagnosis of the patient was not maintained as less than 1 day, which as a strong recommendation has been strictly asked to be maintained, to be kept under 1 day. However, Hospital 2 was observed to be complying with in terms of the language of the posters, which are to be kept in the locally understandable language. As for reasons, the reasons for not wearing, in terms of the reason explained by the facilities regarding separate budget, it was mentioned by the manager that there was no separate component in the budget for tuberculosis activities. The reason for screening to diagnosis delay, as explained by the field staff, was interesting. The facilities, including the laboratories, stay off during the weekends. However, from the community, the patients do sometimes come for testing and have to wait till the next working day. This, I believe, is a key finding and could possibly be a pocket which would help us strengthen the infection control and needs immediate and urgent attention. As for health education posters, the reasons explained were divergent and were identified as a consequence of the shortcomings and the lack of authority. The reasons for not wearing the N95 mask, which are a personal protective equipment to prevent the drug-resistant tuberculosis, nosocomial infection, and the cross-infection,
finding out the key structural and organizational factors that could affect the acceptability, we found out major 5 themes which were increased burden that could affect the adoption of this new intervention, institutional capacity, training and education, linkage, coordination, integration of service, and last but not the least is sustainability. So on a conclusion, we could conclude that diabetes screening was highly acceptable to tuberculosis patient, health facility in charge, health providers, and the program managers. Coordination with multiple stakeholders involved in disease control and prevention activities could be done through the development of technical working groups. Joint collaboration of services was identified as one of the major factors that could affect the acceptability. Therefore, new screening programs could be merged with the current existing routine programs. Like for tuberculosis, we have TB, HIV screening and treatment program already running through the national system. So we can incorporate, or we can do joint collaboration with these programs to embed this new program as to further improve the service among them. Lastly, I'd like to thank Ministry of Health and Population of Nepal, who have been involved during the process of the study from the very early stage till the dissemination. I'd like to thank Nepal Red Cross Society, TDR for their support, and University Gajamada, especially my supervisors, Dr. Yodi Mahendrata and Dr. Ari Probandari for their immense support. Thank you.
Thank you, Sabina. So our 5th speaker is Patricia Maritim, who is a national of Kenya, and she received her master's in public health, in health promotion and education from the University of Zambia in December 2017. Patricia has a Bachelor of Science in Zoology and has a postgraduate diploma in health research methods. She's currently working as an implementation researcher at University of Zambia School of Public Health. She's involved in projects that use implementation research methods to improve access to neglected tropical diseases control program. Today, Patricia will present her work on evaluating the appropriateness of a mass drug administration program in Livingstone District in Zambia. Okay, the floor is yours, Patricia. Is the system working?
It's not working? I have to...
We have a slight technical problem, so... Great. Okay, thank you.
Hello, I'll be presenting on the work that we've been doing as the University of Zambia in collaboration with the Ministry of Health Neglected Tropical Disease Unit. So trachoma is an eye disease that is caused by chlamydial infection, which is spread through flies and fomites. Infection normally occurs among children who are between the ages of 1 and 9, but over a long period of time, the chronic manifestations of the disease, which is usually trichiasis and corneal opacities, are observed. So it is the leading cause of infectious blindness globally, with approximately 200 million people living in trachoma endemic regions globally, and approximately 1.9 million people having severe visual impairment and blindness as a result of trichiasis. In Zambia, Trachoma is endemic in 76 districts out of 115 districts. There are around 24 districts where prevalence is either suspected or unknown. Of these 76 districts, 21 require surgery and 34 require the implementation of the SAFE strategy, which is the recommended guideline for trachoma disease elimination. The SAFE strategy stands for surgery for trichiasis, antibiotic distribution to interrupt infection transmission, and facial cleanliness and environmental sanitation, which is thought to reduce the pooling of infection at community and household levels. So one of the districts where we conducted our work under the guidance of the Ministry of Health is Livingstone District, which has trachoma prevalence of between 10% and 29.9%, requiring full SAFE implementation and an initial 3 years implementation of mass drug administration. So Livingstone District began the implementation of the SAFE strategy in 2015, and currently SAFE implementation is ongoing. We reviewed program data from MDA reports, and we found that coverage levels across health facility catchment areas had great variation. So we wanted to find out what could be the reasons why we're seeing these variations. And we did this by using the theoretical domains framework to look at appropriateness, acceptability, and feasibility of the mass drug administration program. Sustained high coverage levels are essential if mass drug administration programs are to effectively interrupt transmission. So we wanted to use the data in collaboration with the Ministry of Health to try and modify current implementation strategies that were being used to see if they would lead to higher coverage levels. So our objective was to look at factors shaping appropriateness using the theoretical domains framework at health provider level, at community drug distributor level, and also at the community level itself. Our study was set in Livingstone District. We use health facility catchment areas as our sampling frame, and we stratified these health facility catchment areas based on the reported coverage levels. We conducted a concurrent mixed method study and we complemented the data collection, but all our tools and our analysis was guided by the theoretical domains framework. The qualitative data that was collected was through key informant interviews with district officials from the Livingstone District Health Office. And we did 2 surveys, one with community drug distributors. This include all individuals who are involved in community drug distribution in the 2 health facilities that we selected. And then we also did a survey with community members who were particularly interested in looking at participation rates over a 2-year period, because we found that the reporting of participation was high, so we wanted to see, are people really taking part in subsequent rounds of the MDA. So in looking at the participation, at community level, we use a rapid monitoring tool, sampling strategy referred to as lot quality assessment, and we set a threshold where in each ward within a health facility catchment area, we expected to find at least 15 people who have been able to take part in 2 rounds. And we only found that out of the 9 wards that we visited, there was only 1 ward which met the threshold. So we looked at the data we had collected through the survey and the interviews to find out which domains of the theoretical domains framework had the greatest impact on appropriatenteness, feasibility, and acceptability. And we found that this was goals, environmental context and resources, and behavioral regulation. So with regards to the goals, there was a clear understanding of the value of the program amongst district officials. And this was seen by the formation of local action plans through the presence of district-level NTD task forces that brought together different stakeholders. The task force was chaired by the district commissioner, who was also a champion and was involved in MDA activities such as awareness raising, and in some areas he also took part in actual drug distribution. There was observability of the effects of mass drug administration from neighboring districts that helped communities within Livingstone District be eager to take part in the MDA. However, there have been multiple MDAs that have happened in the district over time, and community members stated that they've taken part in too many, and sometimes this would lead to potential refusals. With regard to the environmental context and resources, we found that despite resources being disbursed, they were not always adequate and released in time. Logistical challenges meant that areas that are remote, and some parts of the district are really remote because it's a border district. It's on the border of Zambia, Botswana, and Zimbabwe, means that there are some communities that did not receive MDA, and this poses a challenge because there could be regions where ongoing infection is not interrupted. In order to ensure that workflow systems at health facilities was not interrupted, the use of community-based volunteers and neighborhood health committees within the district made sure that there was adequate human resources to take part in the mass drug administration campaign. Finally, we also looked at behavioral regulation. We found out that in as much as health facility staff and other health providers at district level were involved in ensuring that community health workers were adequately trained, supervised, and monitored, they still observed that some of the community health workers were not doing what was expected of them, especially during the actual distribution. We also found out that at community level, even with the provision of health education and mobilization, the community members still had really low levels of knowledge with regards to disease cause, MDA awareness, adverse effects, and special populations who would be exempt from taking specific medication. Nevertheless, it was important to notice that the district health officials, upon realizing the value of MDA and self-implementation, were able to advocate for more funding for MDA activities. So in conclusion, we found that at the organizational level and at health provider level, there was a good degree of fit within the setting. But we realized that at community level, there are certain changes that need to be made to ensure that communities are better served and are encouraged to continuously take part in mass drug administrations over time. So this can be heightened through practices such as ongoing social mobilization that doesn't happen when an MDA is running, but also happens throughout the year. We also found out that if educational outreach is done continuously, knowledge levels will be sustained throughout the year, and during subsequent MDA rounds, we'll be able to ensure that more people take part. And finally, it's important to tailor messages to specific populations that are ideally resistant to MDA programs. We found that some religions discourage their followers from taking part in MDA campaigns, so it's also essential to think through certain cultural competencies and ensure that these are integrated. As a result of these findings, as a school, in collaboration with the Ministry of Health, we've developed a health system intervention that targets communities living in a lymphatic filariasis endemic region to encourage them to take part in MDA and also mobility management and disability prevention services. So I'd like to acknowledge my supervisors from the University of Zambia, the Ministry of Health, NTD Department, and also TDR for the support. Thank you.
Thank you. And the next presenter is Faustina Gima. She's from Ghana, and she's also studied her master's in University of Ghana. And she's going to present her study on fear of the unknown. And she'll be exploring the psychological factor that influence the implementation of DOT strategy in Accra metropolis in Ghana. Her basic training is in psychology. Welcome.
Thank you for the introduction. Good afternoon, ladies and gentlemen. The title for my presentation is The Fear of the Unknown, exploring psychosocial factors that influence the implementation of the strategy in Accra metropolis in Ghana. TB, as we all know, is preventable. However, DOT, an efficacious intervention for control of TB, has faced a number of implementation challenges, especially in low and middle income countries, thereby reducing its benefits. After 3 implementation of the National Strategic Plan for TB in Ghana, that spanned from the year 1994 to 2013, there are still performance gap in terms of case detection and patient-centered treatment. Currently, about 290 out of 100,000 population are infected with TB. And this figure is about 3 times higher than the figure that was stipulated by the WHO. Primarily, DOT in Ghana and in Accra metropolis is implemented within government health facilities, though this is not highly recommended by the WHO. Private sector DOT and community-based DOT have faced a number of challenges despite a few efforts that has been channeled in that regard. TB patients face the challenge of accessibility to facilities for treatment, and continuity of treatment is also a challenge due to the poor nature of DOT implementation in the metropolis. These have had challenges on the psychosocial well-being of individuals, and as we did some engagement with stakeholders, we realized that this was really a challenge and patient-centered treatment need to be enhanced. Therefore, we sought to undertake this study with the aim of exploring the behavioral factors that influence the successful implementation of DOT strategy. We also explored the coping strategies that are employed in that regard. This was an implementation research employing a qualitative study because we wanted to explore more to know the reasons why DOT is not working. So qualitative study was more relevant in this regard. And theoretically, we used phenomenology, which enhanced the exploration of the subjective views of these TB patients based on their lived experiences. And the views explored how they lived before they got TB, how they enrolled on treatment, and the experiences that they have encountered as they went through the treatment. It was a health facility-based study, and 3 facilities were selected within the metropolis for data collection. We basically used in-depth interviews and key informant interviews for the data collection. This is the study area for the study, and it was conducted in Accra metropolis. And this geographically is a small location. However, it's faced by the challenges of contemporary urbanization, and has a high population and the risks of TB, with a current prevalence of 66 out of 100,000 population. Using purposive sampling technique, we sampled 33 participants for this study. 30 were the TB patients and 3 were key informants. Inclusion criteria for the study included recruiting clinically diagnosed TB patients who are willing and ready to partake in the study. And we also involved the healthcare providers. Exclusion criteria was that TB patients with TB HIV comorbidities were excluded. This was to prevent the difficulty in attaching responses whether to TB condition or to HIV condition. Also, TB patients that were less than 2 weeks on treatment were also excluded from the study, and this was done to reduce the rate of infection between the research and the researchers. The interviews that were conducted were transcribed verbatim. Interviews were done in the local languages, transcribed verbatim in the English language, transported into in vivo for management of data coding, and basically we used thematic analysis for the generation of themes, for refining themes, and key findings that came up was that there were mistreatments that were recorded in all 3 facilities, and this was within the duration of a day to 30 days, and mostly within the intensive phase of treatment. And there are a number of reasons why patients within the intensive phase of treatment missed treatment often. Exploring the psychological factors why patients would not like to continue with treatment or will report on treatment late, we realized that fear, depression were key psychological constructs that were experienced among TB patients. Thus, emotional challenges led to social seclusion, missing treatment, and others interrupted the treatment, whereas others even opted out of that for alternative treatments such as herbal treatment, which is not highly recommended. A key informant was of the view that some patients fear they might die when they take the anti-TB drugs. As a result, they show up for medical care late and the drugs might not work on them, so they die. Exploring some of the social factors, we realized that there was challenges with treatment support system. Patients were asked to bring supporters who will assist them while they are taking the medication at home. However, one of the respondents reported that I was asked to bring one family member, but none followed me except an outsider. This is a clear indication that there is a gap in terms of treatment support where TB patients do not receive the adequate social support that they need in order to continue with the treatment. The coping strategies that were employed by these patients included spiritual measures such as praying, and then to others, denial of their sickness was an agency that they employed to continue with the treatment. The limitation of this study has to be that these responses were self-reported by the TB patients and the participants at home and might not have that validity in terms of measurements using measuring the construct quantitatively. That was not done. To conclude, the NTP can work more in this regard in enhancing patient-centered treatment to overcome the already mentioned challenges by employing implementation research strategies, including education. Education should be increased, targeting the beliefs, the unrealistic beliefs of patients that makes them fear, that makes them depressed, that makes them unwilling to attend treatment. And also there is a need for service restructuring within our facilities, where some of the facilities without professional psychological support should be assisted to provide such assistance to the TB patients when it is needed. Again, we recommend the integration of DOT into community-based health planning services, and effort has been done in this regard, but much more effort needs to be done to the point where patients can attend treatment within their locality without facing so much difficulties. To conclude, I would like to acknowledge my supervisor and the University of Ghana and TDR. Thank you very much for the attention.
Thank you, Faustina. So our next and last speaker is Saha Nasiri. Saha is from Afghanistan. She has done her bachelor in public health at Kabul Medical University. After a short period of working at the Afghanistan Ministry of Public Health, she enrolled in TDR postgraduate scheme master program at American University of Beirut, and she was graduated in 2018. Saha started working as a national consultant at World Health Organization country office in Afghanistan. She's currently working as a technical officer at the Health System Development Department in WHO country office. Welcome, Saha.
Thank you so much for introduction. It's always difficult to be the last speaker. Everyone is already tired, but I'm doing my best to make it as short as possible, promise. I'm also talking about tuberculosis, but in a different context. So the topic that I'm presenting today is a post-evaluation of a tuberculosis awareness campaign in Afghanistan. So tuberculosis is a major public health problem in Afghanistan. Like we have around 189 per 100,000 population of incidence rate of tuberculosis, and around 33 out of 100,000 population of mortality because of tuberculosis. One of the major problems that in regards to tuberculosis in Afghanistan we have is the low detection rate of tuberculosis. So around more than 33% of estimated cases of tuberculosis are not detected by system, meaning that tuberculosis patients are in the community and they are transmitting disease to one another. So there are different factors that are associated with this issue. So one of them is the low awareness of people regarding the signs and symptoms of tuberculosis, and also the stigma that surrounds this disease. So far, the Ministry of Public Health and the National Tuberculosis Control Program, or NTP, in Afghanistan has done so many things in order to tackle this issue, but most of their interventions were in the health facility level. In 2017, for the first time, the NTP, or National Tuberculosis Control Program, they launched an awareness campaign in the national level. So they wanted to increase the awareness of people regarding tuberculosis in order to decrease the stigma and eventually increase the case detection or case notification rate of tuberculosis in Afghanistan. So the objective of this study is we want to see the impact of this awareness campaign on case notification rate. So we want to see if they were effective or not. At the same time, we collected some process indicators data also in order to see like how they really implemented this awareness campaign. So we used the REAM framework for the impact and process evaluation of this campaign. So this framework helped us to see not only evaluate this campaign not in terms of its efficacy, but also to see the process, how it delivered also. And for the process evaluation, we collected data from the provincial reports that we had of the campaign. And also we did some formal and informal meetings with those people who were involved in this campaign, whether they were in the national, in the NTP, in the capital, or they were in the provinces. And also we did some secondary data analysis from using DHS, CSO, and HMI's data just to see our treatment and comparison group if they are similar in terms of their characteristics or not. For the impact evaluation, so just first to say the pointer is not working, fine. So if you see here, we have 21, this campaign was launched in 21 provinces in Afghanistan. So out of 34 provinces, 21 provinces did take the awareness. It was because they could not take it in all because they had limited budget, so excluded 13 provinces. Out of those 21 of them, 11 of them received the campaign during the fourth quarter of 2017, and 10 of them received the campaign during the third quarter of 2017. So those in orange that received during the third quarter are our treatment group. Out of the 11 provinces that did not receive the campaign, so 11 of them were very similar to our treatment group. So we took those provinces as our comparison group. We excluded 2 of provinces because they were highly insecure provinces and they were not similar to our treatment provinces. We are explaining our findings within the framework. So it's talking within 5 dimensions of framework, which is reach, effectiveness, adoption, implementation, and maintenance of the program. In terms of the reach, so they were in the nature of this campaign was in a way that they used to go in the settings where high-risk groups were there. So because their budget was limited, they were not able to gather people, and instead they were going in the places where people are already gathered. For example, in schools, they were giving campaign for school students, school teachers, mosques, for the women's societies, women safe houses in these areas. So this is why the target groups there was a variation in terms of target groups across provinces. And that also another thing in their reach was the number of people who received the campaign in those provinces. When we look at them and compare them with the total population of that provinces, we found that this number was very small. That might affect the outcome of the campaign later on. In terms of effectiveness, so here we look at the data, we compared, I forgot to say in the methodology that we applied difference methodology for this evaluation. And also we foresee the change in the outcome. We look at to our findings for the CNR, case notification rate, or that case detection, in third and fourth quarter of 2016, and compared them with the same quarter on 2017. And we did this because of the seasonal pattern of tuberculosis in Afghanistan. Because in Afghanistan, during the first and fourth quarter, usually it's snow. And people there, as it is a mountainous country and it's heavy snow, there is a barrier between people and health facilities. So they cannot go to the health facility. That's why we have lower case detection between first and fourth quarter. But during the third and second quarter, it is normal. So here we find out that when we look at the case notification rate on 2016 and 2017, both in our comparison group and in our treatment group, in both of them there is increase in terms of case notification rate. However, when we look at the comparing between the treatment and comparison group, we see that the treatment group, which is in blue, it is have lower case notification rate compared to the orange one, which is our treatment comparison group, meaning that there was not any impact of this awareness campaign on case notification rate during the campaign or during the quarter 3. We look at the same comparison, we did it in quarter 4, meaning that 1 quarter after the conduction of this campaign. We realized that again, there was not any impact of this awareness campaign on case notification rate. So there might be like, another thing was during the implementation of this campaign. So before that, during the adoption, so the majority of the participants they were willing to participate in this campaign. However, in some cases, in very few cases, it happened that in some schoolgirls, the participants were not willing to participate in this campaign. So it was because in some schools, as Afghanistan is a culturally restricted community, and people, sometimes in some girls' school, all the staffs are girl and all teachers are girl, and it is not allowed for men to enter those schools. And in most of cases, these people who were giving the campaign were men. So they were not able to enter those schools, and they excluded from, eventually they exclude them from the campaign. So why I'm raising this issue is, although it happened very rarely, but having said that in Afghanistan, women are more vulnerable to, prone to tuberculosis compared to men. We have more than 55% of cases comes from women. And also a study that have conducted recently showed that women are more prone to tuberculosis because of several reasons, which are they have lower birth interval because they are getting married earlier, and because and the main reason is because they are the main person, because they're taking care of the patients at home. So they are more, they have more exposure for them to get tuberculosis. And here, by excluding them from these campaigns and this stuff, so we made them even more vulnerable. And also, some other external factors were also attributed for these findings. And some, which one of them was security, the main of them. In some provinces, in some villages, because they were very insecure, although there were people, like high-risk group people were living there, but this group of campaigners were not able to travel in those insecure provinces. So eventually they exclude those areas also from the campaign. So as a result, we can say that this TB awareness campaign had no impact on case notification rate or case detection rate in Afghanistan. So it might be because of several implementation shortcomings that was across this campaign. And also it might be because of some external factors such as security that might affect this campaign. And that's why, as a recommendation, we are recommending further quantitative and qualitative research studies in this context in order to see what are the main reasons behind this low detection rate of tuberculosis in Afghanistan. Is this awareness or something else? And also we are requesting for for designing some more theoretical-based campaigns. I mean, because when we are saying change, because such campaigns are changing the social norms or changing behavioral factors. So it's not enough to only aware them with a flip chart or a presentation. So we need to design our campaigns more in a theoretical frameworks. And also we are requesting for more work on documentation of the process, and also to having action plans while they are conducting their campaign across, when they are including several provinces, just to limit the variation across provinces. And also at the end, we are recommending to involving more female facilitators while doing such campaigns in Afghanistan. I have to say, I did this evaluation during my practicum session in NTP, National Tuberculosis Program in Afghanistan, while I was a student at American University of Beirut, and I did this under supervision of my professor, Dr. Maya Salverding, that I'm very grateful for. Thank you so much.
Well, thank you, colleagues, and now we come to the end of the 7 presentations.